So, dear Professor Karin Diserens, we are here for the 12th World Congress of Neurorehabilitation here in Vienna, organized by the WFNR. What is your first-hand opinion of the event so far, and have you participated in any previous editions?
Yes, I have participated regularly. I'm chair of the SIG Early Rehabilitation, and in this function I participated to the scientific programs. The impression is that as each congress, WFNR succeeds to bring together the specialists in the different domains, and it's very dynamic.
And how was the first one that you participated in, the first congress in Istanbul?
Yes. And that was very, very interesting because already at this meeting we had a very good collaboration with the different countries and specialists, and these collaboration maintained in the years after.
All right. So what do you believe is the overarching theme of this year's Congress?
So as each Congress, it covers the main subjects of rehabilitation, and it succeeded especially this time to integrate innovative techniques for diagnosis, prognostication and treatment.
So how do you believe that interdisciplinary interaction plays in this event?
They bring really together a networking, and this networking gives also the possibility to further research internationally.
All right. What are some limitations regarding access to care for patients suffering from disorders of consciousness?
Yes, disorders of consciousness is a very controversial subject, and especially the last years. And the limitations is that the definition is not all the same, and the methodology to evaluate it.
How is diagnosis during the acute phase in these disorders?
The diagnosis in acute phase is very interesting and very important, and should not be limited on scoring. Mm-hmm. The focus of our research, especially in our group, is to enlarge the evaluation by scoring. It's important, but also by observation of motor behavior and a correlation with the multimodal evaluation. It's very important to give already a feeling for the part of a neurologist's evaluation is coma in the pre-graded and post-graded teaching, and it should be as an HSS for stroke or movement disorders, should be a part of evaluation daily life, and the integration of neurologists and neurorehabilitator in the intensive care is a very important point we have to develop and to defend in the other centers.
All right. What are some prerequisites for an integrative approach to disorders of consciousness?
First of all, we have to choose the good methodology of diagnosis. As I said, scoring the well-standard evaluation scores, but also the observation of motor behavior. We have to look that this evaluation is integrated in the decision life pathway already in the acute phase post-sedation, and there is a communication with the acute professionals as neurologists, neurosurgeons, intensivists, and the therapeutic teams, and the post-acute phase, and especially afterwards for the ambulatory phase. So the goal assessment since the acute phase is very important.
What are the main advantages and limitations of brain-computer interfaces and virtual augmentation or virtual reality developments in contrast to classical rehabilitation?
So for BCI, brain-computer interface, when it's really BCI, it means the control of an environment by brain activity. It is an opportunity for patients who can communicate, like a real locked-in patient. Nevertheless, we have to be very careful that for the patients who have the gap to interact and to command verbal stimulations, we have to be aware that the patient has not aphasic problems and vigilant problems and are not able to give a robust signal on EEG. And it has to be motivating for the patients. So it's we have to choose the good patient for the BCI.
And who can decide when the patient is autonomous?
We could give him with BCI larger autonomous life, but it could be also very difficult for the patient, too difficult to concentrate. So we should look for other possibilities to interact with the patients. And the same is for virtual reality. It's a new innovative technique. It's interesting, it's motivating, but the patient has to be cognitive on the level with his cognition to follow the virtual reality and to use it. If he can use it rightly, it gives the possibility to follow treatment ambulatory and stimulates the motivation.
My last questions would be, are outcomes of disorders of consciousness sufficiently evaluated in the short and long term?
This is still a point which is discussed and researched. The conclusion we heard today, a very good talk, is that we have to choose scales, but we have to give an individual goal assessment by the families, by the patient, based on one possibility, the International Classification of Functioning and Disability, the ECF, and that's a very good tool, a very good approach to show that we are in phase with the patient's goals, family goals, and the specialist goals.
So thank you for the interview and thank you for being here.
Thank you.